Assalamu alaikum. Dear colleagues, ladies and gentlemen, good morning. Okay.
Settings on the screen so we extend the ticket. دقيقة. بالضبط لازم every time نسوي project.
أو خليها هيك بدون
لا بس دوس هذا.
بس دوس هذا.
هاي خلاص.
لا تخليها منا. تريد تخليها منا هيك شوف أو هيك كيف.
بس دوس هذا بالنص بالنص.
هاي اوكي.
بالنص. سويها اوكي. هاي بالنص دوسها.
اوكي.
هاي هسه صار.
I'm going to talk about diabetic vitrectomy. When we started up doing vitreous surgery, the concept was, well, let's remove opacities from the vitreous. Let us just take the blood and get out of the eye. And we came around way from that time to all the sophisticated instruments that have been developed and all the techniques that are now available for diabetic vitrectomy. So I'm going to proceed in this point to review pars plana vitrectomy for diabetic retinopathy. Now, what cases should probably not have surgery? And I have listed here a few areas in which we should probably not subject eyes to vitrectomy surgery. The case of a patient with long-standing traction or traction rhegmatogenous retinal detachment of the macula with extensive fibrosis and thin atrophic retina. So eyes with long-standing retinal detachment with good vision should probably be observed. Otherwise, we can only lead to harm the patient we do surgery. Second, extensive neovascularization of the iris, lens, or retrolenticular area. Those are likewise poor candidate for surgery. Chronic glaucoma with long-standing poor vision are also poor candidate for surgery. With physical eyes, doing further vitreous surgery will often make the eye more painful and more worse than prior to surgery. So when should we do vitrectomy surgery for a diabetic patient? We should do it after reviewing a pan-retinal photocoagulation for a small vitreous hemorrhage, and that should be your first approach to try to get as much laser treatment as possible. And then if it's unlikely for spontaneous clearing to occur, then we should timely proceed for pars plana vitrectomy. Nowadays, we don't want to lose opportunity to improve vision in a dense vitreous hemorrhage with organization of the vitreous. And we tend to operate early and not to wait 3 to 6 months as in the old days. Now, these are some of the indications for vitrectomy in a diabetic patient, sorry, non-diabetic patient, non-diabetic. The patient with vitreous hemorrhage that obstruct his vision is the most common indication. Recurrent vitreous hemorrhage despite adequate PRP is the second most common indication. Vitreous hemorrhage, major vitreous hemorrhage that prevent the application of laser. Vitreous hemorrhage in an eye with iris neovascularization. Those eyes are going to progress neovascular glaucoma unless we remove the hemorrhage and apply laser treatment. Ghost cell glaucoma, this is a relatively rare indication, but it does occasionally come up. Monocular patient with immediate visual needs, and large subhyaloid hemorrhage that can cause macular puckering. Now let's move on to the second classic indication, and that's the indication for traction retinal detachment involving or threatening the macula. In the old days, we used to wait for the macula to become involved or detached. But in a diabetic patient, when the macula become involved and detached, the prognosis for vision is very bad, it's very poor. So we tend to operate before the macula comes off. The third classic indication is the traction rhegmatogenous retinal detachment. And this is a situation in which there is a convex retinal detachment, often caused by thin or little holes in thin atrophic retina that might cause more bullous detachment. And those eyes are sometimes the most challenging cases because the retina is highly elevated and fixed only by fibrovascular tissue. Now, there is a miscellaneous category of indications for diabetic patient, and are listed here in this slide. I will briefly run through them. Progressive fibrovascular proliferation, epiretinal membrane, iris neovascularization, traction on optic nerve with visual loss, posterior hyaloid traction, and macular hole. Nowadays, diabetic vitrectomy is usually performed as an outpatient procedure. We bring and admit patient to the hospital only if we are doing surgery on the only eyed patient, or if there is complex medical problems, or if we require positioning monitoring. But in most of the patients, we do this surgery as an outpatient case. We almost always use local anesthesia with sedation and a monitor to standby anesthetist. And we found that this caused fewer systemic complications and faster recovery. Now, what about the problem of a diabetic patient that have coexisting cataract with indication of vitrectomy? We do a combined procedure, that's to say phaco-vitrectomy procedure. If there is inadequate visualization through the lens to do vitrectomy, or if the lens is presenting a preventing access to the epiretinal membrane, to the peripheral epiretinal membrane and anterior hyaloidal fibrovascular proliferation. Or if we have an advanced nuclear sclerotic cataract. Now, basic concepts of vitrectomy. I think the steps of vitrectomy are known to everybody here. It includes removal of the anterior and mid-vitreous, identification of the posterior hyaloid face and removal with the posterior vitreous, performing fluid gas exchange, and doing laser if necessary. Now, what about bleeding? Hemostasis is a big problem during removal of plaques of epiretinal membrane and fibrovascular proliferation. But we have several things to do to stop bleeding. We can use aspirating diathermy, we can use a traditional diathermy, and if these fails, we might raise the height of the bottle, and not uncommonly, the bottle might go up to the ceiling. The last resort is using a thrombin in the infusion solution. Now, when we decide to use a scleral buckle or an encircling scleral band during surgery, well, if we are creating an iatrogenic retinal dialysis from passing scissors and instruments in and out of the eye. Second, if we have persistent peripheral vitreous-based traction, pulling and causing detachment, then obviously we'll support that with scleral buckle. And third, it's relatively rare, it's relatively unusual to use it with the traction associated with peripheral fibrovascular proliferation, which cannot be safely removed. Now, what about complications after vitrectomy? Neovascular glaucoma was traditionally a very frequent complication, especially in aphakic eyes and in eyes with persistent postoperative retinal detachment. Now, with laser treatment and maintaining a barrier between anterior and posterior segment, neovascular glaucoma is less common. Cataract can occur in some patients after surgery, but not immediately postoperatively. Recurrent RD with PVR. And the problem that we see nowadays is the problem of recurrent vitreous hemorrhage after surgery. Anterior hyaloidal fibrovascular proliferation and massive anterior segment fibrin. And there is no good resolution for this problem, but the fibrin will often clear up with time. Now, in summary, before forgetting diabetic vitrectomy for a diabetic retinopathy, the use of local anesthesia have reduced operative times and decreased the systemic risk to the patient. The outcome of vitrectomy for eyes with diabetic retinopathy have improved through better instrumentation and techniques, and appropriate and timely use of vitrectomy will improve vision in the majority of eyes requiring surgery. Now, this is my last slide. When do you decide whether there is enough pan-retinal photocoagulation placed for a patient who has recurrent vitreous hemorrhage? Now, I think it's a common point along the line. We have to say, where is the hemorrhage is coming from? Now, if that hemorrhage is coming from an elevated fibrovascular proliferation, then we can put 5,000 burns, and still we will never stop it. So at some point along the way, we have got to decide whether it is becoming inconvenient for the patient to do his daily activities to a time where vitrectomy is appropriate. So I would discourage doing the supraretinal photocoagulation, where you create an atrophy from the arcades to the ora serrata or to the equator, and the super PRP cases, because you have such a terrible influence on the visual field as well as optic atrophy, that I would prefer to get an asymmetric pararetinal photocoagulation and then go up for vitrectomy. Now, this is a video clip, a short video clip.
نزل منه.
This is a case of diabetic retinopathy with fractional retinal detachment involving the macula. This is what we call it a Wolff jaw configuration. This is what we call it a Wolff jaw configuration. It's the most challenging cases for vitreous surgeon. And the strategy here is doing a bimanual technique to remove the membrane. And sometimes you got bleeding, sometimes you got attractional breaks during peeling and dissection. Now we are eating the membrane. The last step is refining or to remove the residual membrane that are very strongly attached to the arcades. Now in this situation, you can't raise the bottle because you are going to damage or you are going to precipitate more ischemia for the retina. So you should dissect carefully and not to cause heavy bleeding. Using a Chandler pipe light will make you do the bimanual technique. We are creating here an fractional break. This is doing further vitreous cleaning of the periphery. This is a good indentation of the sclera, of the periphery of the sclera. This step is doing fluid gas exchange through the break. Sorry, it is not so clear. And at last, we will replace this air with silicone oil, a non-tamponating agent. This is the silicone oil. Now we are filling the cavity with the silicone oil. And the final step is doing endo laser photocoagulation. The vision was down to figure 1 meter. Also, it was 636. The last step is removing of the Chandler light. Sometimes you need to put the stitch if the sclerotomy is leaking. Thank you very much.
Thank you very much, Dr. Mehند, for this very nice, comprehensive session about the diabetic vitrectomy.